Namaste and good morning. Respected chairpersons. Let me at the outset thank the organizers for giving me this opportunity. And when Amitabh told me about talking about interventions in children less than 2 kilos, I think he called me at around 8 in the night. I accepted. And I thought about the cases next day, about the cases which I have done less than 2 kilos. They're far not too many. So the next thing what you do is call your friends. So I called Dr. Edwin, Dr. Shiva, and my own fellows in Delhi, Dr. Gaurav, about the cases which they have done. So today's what I'm going to show you is a cumulative experience of all of my friends and colleagues in interventional cardiology. Being challenged in life is inevitable. Being defeated is optional. Why I put this slide is because the surgeons generally do a good job in children less than 2 kilos. So when you went to venture a procedure in a child, that's more challenging for the pediatric interventional cardiologist because you got to do a good job and less harm. So let's look at the common procedures done in this category. That's the PDA stenting, balloon dilatation of aortic and pulmonary valves, PDA device closure, balloon septostomy, coag dilatation, especially in a preterm child, perforation of pulmonary valve, and RVT stenting in severe tautology for child who presents with spell. So the important thing is how to plan for these cases. And how I do is, one of the important things is to do a detailed echo by yourself to avoid surprises. Do all the measurements that is needed for the procedure. Just measure everything. Consider other modalities of CT and MR in case you have some unanswered questions. Visualize the steps before you actually do the procedure. Plan for the vascular access that you intend to do. Discuss your strategies with your colleagues. Is it a great idea? What are the other alternatives? Anticipate the potential complications and strategies to get out of it. Order your hardware. And then you need to have a good neurology team in case that you do not have a dedicated pediatric intensive care unit. So I actually have a good neonatal ICU and I do these cases, and then those guys in the neonatal ICU takes care of the kids. So the checklist before the procedure is a complete echo, going through each step of the procedure with the cath lab tech and colleagues, making sure the hardware, the procedure, and potential complications are available, informing and discussing with your team. The anesthesia team should know what you're actually going to do, because many times when the critical point of time when you're deploying the device or ballooning, they should know what that procedure you're doing. You may need additional support at that time. Planning for the non-complications, have a plan B and a plan A and plan B, proper consent. Proper transport of these kids is essential because these children get hypothermic in no time. Discuss with the surgeon about the procedure and plan for a post-operative care. Hardware, which I think is essential, is a 3.5 French, a 4 French, a 5 French cook sheath and a cordage sheath, a snare, a 5 millimeter, 10 millimeter microvenous snare, 4F RC catheter. Most of the manipulations which I do are with this 4F RC catheter, 4F and 5 French balloon Swan-Ganz catheter, and shuttle sheets. The procedure strategy would be a proper transport of the sick kids and preterm. Occasionally, you can do the procedure even in the neonatal ICU, especially a balloon septostomy in a preterm kid with TGA, you can plan it on the neonatal ICU. Temperature homeostasis is all the more important. So transport the kid in a warmer, prevent exposure hypothermia with proper equipment for warming, use warm saline for all your flushes. That's very important. Important infusions should be ready, like prostaglandin, dopamine infusions must be ready in the cath lab. Access, try to be mostly use venous, arterial if only essential. Hand injections, use diluted dye. I use 3:1 dilution. Sometimes you can use more dilution. You just need to check what is to be done. Use 2D echo and 2D echo maximally for positioning of the balloon and devices when possible and reduce the dye. Complete the procedure expeditiously. Good is always better than perfect. So this is the vascular access. Now we have the ultrasound guided, the linear probes are excellent tools. It's difficult for us because we are been in the field for some time. So it's difficult to teach the old hands the new skill, but I've also learned using the ultrasound to get access, and this allows me to get arterial and venous access easily without multiple punctures. This is the vasculature becomes very, goes into vasospasm immediately after 2 to 3 punctures. So getting the access initially with initial prick itself is very, very important. It saves time. Let me go through a few procedures which I've done. PD occlusion in preterm children is the commonest circumstance in which we are called to do it. Preterm PD is an enigma. There are more questions than answers. What is hemodynamic significant PDA? When should we treat? Who should we treat? How should we treat? All are questions still not very clear. So when do I do? Failure of medical and conservative therapy. There is significant volume overload, inability to wean from ventilator or oxygen requirement, or has persistent congestive heart failure symptoms. So before procedure, check the anatomy, especially the PDA. Preterm PDAs can have varied anatomy. It can narrow at both ends. It can be long, it can be large. So size is important. The morphology is important. The weight of the baby is important, and associated comorbidity is also important. You have various devices. We have the Piccolo. We have the, I just forgot the name, the AD occluders, and also the vascular plugs now available for PDA. Depending upon the size of the PDA, the important thing is you need to deploy the whole device within the duct, because otherwise there's always a potential for LP origin stenosis or coarctation, neonatal acute coarctation. So when I do it in preterm PDAs, I use venous access, heparinize, use a 4 French RC or Swan-Ganz, or a 3 French multipurpose catheter, PTC wire for all manipulations, micro catheter for support to push the sheath. The delivery system is a 4 French Falcon, gentle hand injection both in lateral and LAO, use an appropriate size device, positioning both in fluoro and echocardiography. Make sure you are in good position before you release, because otherwise things can get tricky. From anesthesia point of view, have at least 2 arterial lines for drugs. Temperature monitoring is essential. ET/CO2 monitoring is very important, and managing hemodynamic instability, especially when you deploy the device and when you're manipulating this child for echocardiography, especially to look for the flow in the descending aorta, for checking for the obstruction in the descending aorta. When you manipulate this kid, this children develop hemodynamic instability, and you need the anesthetist to manage that particular point of time. So this article tells you about the ductal closure in children weighing less than 1,500 grams. The most important complications being duct embolization, significant LPS stenosis, and bleeding leading to a hemopericardium. So these things can happen, and you got to manage them. So this is a 650 gram child, grown up to 1.1 kilos in 2 months. Several attempts were made to close the PDA medically, but was unsuccessful. The PDA was large, and we used a small PDA, the 5.3 PDA occluded device to close the PDA. And this is the angiographic pictures, and you can see how the good LPA flow is. And we've released the device, making sure that there is no obstruction to the aorta. The next common procedure which we do is PDA stenting. And I took this article from a fellow of mine, Dr. Gaurav, and he has done around 5 PDAs in a preterm kids. And the important issues, I think the procedure, the steps are nearly the same. The techniques is the same. Only thing, you got to manipulate the catheters carefully so that you don't develop any complications. And stent displacement is the most dreaded complications, and you got to be careful about it. Although the principles are remaining the same. Coming to balloon dilatation in children less than 2 kilos, important thing is that I use cut pigtail to cross them. And detailed echocardiography about exactly where the orifice is I think is a good strategy. It allows you to position a catheter in such a direction so as to make sure your wire enters it. Pacing is usually very difficult in preterm babies, and since the cardiac output is not too much, you usually don't do it. You need it. And use a small balloons always in case you want to dilate aortic valve. This is a child who was less than 2 kilos, a severe coarctation. It's a preterm kid, 1.1 kilos. We use a PTC balloon to dilate initially, and then a TISHAC TISHAC mini balloon for dilatation for getting temporary relief. And then this child had a neonatal coax repair after 3 months. Sometimes venous access from the femoral end may not be possible, and then you need to have a neck access. This is a child in whom we had a lot of difficulty in getting it right ventricle. We use a neck access to enter the RVOT, and we used a stent to open up the RVOT tract. Often use echocardiography to assess your outcomes, and this is how the RVOT flow was established after deploying the stent. Sometimes you can get some wonderful innovations if you go through literature. This is one thing which I found out in a Saudi article. So here they use a snare for RVOT perforation. They introduce the snare through the PDA end to the RVOT. And then when you use a stiff end of the catheter to puncture the pulmonary valve, it's easy to snare it inside the pulmonary artery, and you know you're not damaging or entering into outside the heart. So this is a technique which is interesting. And if you read through it, probably you can come up with some genuine ideas which will help you in such interventions. The complications mostly are preventable. The most important reason why I found when I got into trouble is when I was overconfident. Always ask for help. Plan always for a long haul. Get your blood transfusion, blood group cross-match done, inotropic support. When needed, restart your prostaglandin, volume support, and ventilator assistance. As I said, hypothermia is an important thing. Prevent blood loss. Complications happen. It provides a great learning experience. Embrace them, but brave it out. You will always be able to get it out of it. To conclude, intervention in children less than 2 kgs can be done safely. Proper planning and suitable hardware is essential and crucial. Complications happen, and the importance of a good team cannot be overstressed. Thank you so much.
Thank you, Dr. Anil. We can take 1 or 2 questions if there are any. Yeah. Okay. There no. Yeah. Prem. Yeah. Go ahead.
So, do you take a arterial line for your PDA devices in preterms?
No.
And for PDA stenting, if there is LPA stenosis, either origin or LPA is smaller, would it be advised to go ahead or send them for surgery?
So if the LP stenosis is significant and if I feel my surgeon can handle it, I usually send it to surgeon. But I have also stented both RPA and LPA simultaneously with 2 stents in bifurcation stenosis. So if the duct is sufficiently large, I have placed 3 millimeter stents into both branch pulmonary arteries to provide significant palliation in at least 1 or 2 kids. And these children have undergone Glenn and corrective surgery later. So it's possible.
No, you're talking in a preterm thing, stenting regular babies?
I suppose suppose that question was not for preterm.
Okay, probably. You wanted in the preterm frame? Smaller babies, okay.
Preterm, I think it's sufficiently difficult. So I usually deploy it in one of the easier pulmonary arteries that's available.